This content is based on Essentials of Biostatistics in Public Health by Lisa M. Sullivan. Before you analyze data, you need to understand how that data was collected. This chapter explores the many ways public health researchers design studies to answer real-world questions. Why study design matters. Study design is the foundation of good research. It determines how data is collected, how valid the results are, and what kind of conclusions we can make. A strong study design increases credibility, reduces bias, and ensures that public health decisions are based on solid evidence. Whether it's choosing a survey, an observational study, or a randomized trial, picking the right design helps us answer the right question the right way. First is understanding the vocabulary. Study designs are built around key terms. An exposure is what we think might affect an outcome, like smoking. An outcome is what we are measuring, like lung cancer. A risk factor increases the likelihood of disease, but doesn't always cause it. And remember, association is not the same as causation. Also important is the timing. Prospective studies look forward in time, while retrospective studies look backward. Second is observational study designs. Study designs fall into two major categories, observational and experimental. In observational studies, researchers observe what happens naturally without interference. They collect data on exposures and outcomes without assigning treatments. In experimental studies, like randomized controlled trials, the researcher actively assigns exposures or treatments. This allows us to test cause and effect relationships. Experimental designs often provide stronger evidence for causation, but may be limited by cost, ethics, or feasibility. Understanding this distinction helps us evaluate how reliable a study's findings may be. The case report and case series. A case report describes a single patient with a unique or rare condition. A case series includes several similar cases. These are descriptive, no comparisons, no control group, just a useful way to spot patterns or generate hypotheses. The cross-sectional survey. This design collects data at one single point in time. It measures both exposure and outcome simultaneously. For example, we may survey a population to see who smokes and who has asthma. While it's great for estimating prevalence, it can't establish whether smoking caused the asthma because we don't know what came first. The cohort study. In a cohort study, participants are grouped by exposure and followed over time. This can be prospective or retrospective. Cohort studies are great for determining incidence and exploring temporal relationships, but they can be time-consuming and expensive. The case control study. In this design, we start with people who already have the outcome. These are the cases. Then we compare them to similar people without the outcome, the controls. We look backward to see what exposures they had. This method is efficient for rare diseases, but it's vulnerable to recall bias because it relies on participants remembering past exposures. The nested case control study. This design is like a hybrid. It pulls cases and controls from an existing cohort. It uses previously collected data, so it's more efficient and often more reliable than traditional case control studies. Third is randomized study designs. Now let's move to experimental studies where the researcher actively assigns the exposure. The randomized controlled trial or RCT. This is the gold standard of study design. Participants are randomly assigned to treatment or control groups. Randomization helps balance confounders. RCTs provide strong evidence for causation, but they are expensive, complex, and not always ethical. The crossover trial. In a crossover trial, each participant gets both treatments just at different times. For example, a patient might receive a new drug first, then switch to a placebo. The key is the washout period between treatments to avoid carryover effects. Each person acts as their own control, which increases statistical power. Fourth is the Framingham Heart Study. This historic prospective cohort study began in 1948 and followed thousands of residents in Massachusetts. It helped identify critical risk factors for cardiovascular disease, including smoking, cholesterol, and high blood pressure. It is one of the most influential studies in public health history. Fifth is more on clinical trials. Clinical trials follow strict ethical guidelines. They often involve blinding, where participants or researchers don't know who gets the treatment. They also define inclusion and exclusion criteria to protect participants. The FDA oversees these trials and determines if a treatment is approved for use. Well designed trials can support life saving innovations, while poorly designed ones can mislead. 6. Why sample size matters. Sample size is critical. A study with too few participants may not detect real differences. This is called being underpowered. But enrolling too many can waste resources or raise ethical concerns. The goal is to enroll just enough to get meaningful, valid results. Study design is the foundation of biostatistics. Whether you are working with case reports or clinical trials, choosing the right design ensures the research answers the question it was meant to. It also determines how data should be analyzed and interpreted. In future chapters, we'll build on these designs as we explore statistical tools like confidence intervals and hypothesis testing. Thanks for watching. This content is based on Essentials of Biostatistics in Public Health by Lisa M. Sullivan.